at SummaCare, we also recognize that we're not providers of care. So as we sat down to say, what is really SummaCare's objective here, it was really what you see on the screen here. That is, we recognize that we're really navigators. Obviously, we help integrate the financing and delivery of healthcare, but really act as navigators to your patients, helping them navigate the healthcare delivery system. And so, this is kind of what we settled on a few months ago, and thought we'd share that with you this morning in terms of how we see the vision of SummaCare and what role we play in the healthcare delivery system. I won't get into this. Most of you know SummaCare. We've been in this for a long time, going on almost 30 years. We understand provider needs. Hopefully, we're very responsive in our partnership and relationships with you. We know that things won't always go 100% correct or the way that we'd all like them to go, but I think the test of that is how responsive are we when things don't go as planned, and helping you solve some of your issues, whether it's eligibility, whether it's benefits, whether it's claims. We are obviously here for you, and hopefully you've got a great experience with SummaCare in that regard, as well as a partner. Obviously, we're provider sponsored. We're also nonprofit, so we're not beholden to shareholders or private equity demands. And unlike most other plans, we are truly the only plan focused entirely on this Akron market. So, and obviously a population health focus as well. I won't spend too much time on these slides. This is just some of the accolades and awards for SummaCare. I think we're a 4.5-star plan, but I think Sue's going to speak more to this when she gets into her slides. So Jen, if we can move through the next couple slides fairly quickly. Let's go through that one too. I think Sue's going to spend some time. And then just generally speaking, we are NCQA accredited and 4.5-star, and we're hoping sometime in the next few days, actually, we'll get the new star ratings for 2023 from CMS and be able to speak to that as well. So we're pretty excited about what that might mean as well. But lastly, again, just thank you for your collaboration and partnership. We really appreciate everything you do for our members and your patients. We really appreciate your collaboration on many of our quality initiatives. Some of you are in value-based arrangements with us, and we certainly appreciate that as well. And overall, we just think it's a great partnership, and we think we know that once members join SummaCare, because of the service that you provide to them and the service that we provide to them, that they, for the most part, stay with SummaCare for a really long time. And then lastly, I just wanted to highlight, because we are a local plan, we launched an initiative last year called Lift Up Local. And so what we do is we find a local small business that is in need of some support. So it may be a 1 or 2 person kind of a business that doesn't have a marketing or advertising capability or ability to kind of promote their business. So we choose one, and we help them develop materials and marketing campaigns and things of that sort. So this is the one last year. Mandy Forlina, president of Safety Training Group USA, was the individual business that we chose to assist. And so we've really helped her expand her business, give her materials that help explain her business, and as a result, continue to help her grow her local small business as well. So just another reason why SummaCare is focused on local, and we're certainly focused on providing healthcare on a local basis in partnership with all of you. So thank you very much for your time this morning, and Jen, I'll turn it back over to you.
Thank you, Bill. We appreciate you joining us today to kick off this event and for sharing those highlights that make SummaCare so great. Essie, are there any questions or comments in the chat box for Bill?
Nothing at this time.
Okay, moving right along. So now on to our keynote speaker, William Fiala, Professor of Practice at the University of Akron. Bill has a bachelor's in finance, master's in business and economic history, is a registered medical assistant, a certified professional coder, certified coding specialist, physician-based, and an ICD-10 trainer. Did I also mention that he has his own business that serves dozens of practices and facilities where a fair amount of his work involves coding audits and compliance issues? Oh, and he's authored several publications. He does it all. Bill, we are so thankful to have you in today's event, and the continuing education credits are, thanks to you. So Bill, the microphone is yours.
Well, thanks, Jen. And I appreciate being invited to talk to you all this morning. And we're going to talk about Z codes this morning. So let's go ahead and get started with Z codes. And typically there are two uses for Z codes, and Z codes are properly Chapter 21 of ICD-10-CM. And there are two purposes predominantly for these codes. Most of you know that first use, and those are the Z00 codes for well visits. And predominantly that's going to be primary care, but a number of specialty practices use those Z codes for exams. Our attention this morning is going to be on that second purpose for Z codes, that additional information. And let's look at that additional information. And the additional information includes history of, something missing, that acquired absence, an artificial opening, transplantation status, device presence, long-term drug therapy. And let's look at how we use those different additional information codes. And we're going to start with history of. When do you use a history of code as opposed to a code from chapters 1 through 19? And there are some general rules in the coding guidelines as to when you use a code from chapters 1 through 19. In chapters 1 through 19 are the illness and injury codes. So I'm sick or injured. And I'm going to use a code from chapters 1 through 19, predominantly when you see one of those two things in the bulleted items. I have clinical signs or symptoms of the illness or injury, and or you're treating me for the illness or injury. And that really ought to make sense. I'm going to use an illness or injury code, a code from other than Chapter 21, when there are clinical signs and symptoms of the illness, and you're treating me for it. So something other than the history of code when those two circumstances exist. Let's look at some examples. We'll start with malignancies. Here we can go to the actual ICD-10-CM guidelines, and you see me cite the guideline. I want you to go to the second line here. When no further treatment is directed to the site, and there's no evidence of any existing primary malignancy, code from category Z85. Very consistent with don't use a code from chapters 1 through 19 if you're not going to treat it and there's no clinical evidence of disease. You're going to use a history of code. Let's look further at the guidelines. A little further down in the same chapter guidelines, when the primary malignancy has been excised, but you're still going to treat. And the example they give is you had surgery, but you're going to do treatment, radiation treatment or chemotherapy. You're still going to use the primary malignancy code. Think about those general guidelines. Clinical signs or treatment directed. Here, you're still directing treatment, so you're still going to use the primary malignancy code. But you read a little further down, if you excise the lesion or it's eradicated, think radiotherapy or chemotherapy, but there's going to be no further treatment and there's no evidence of disease, then you're going to use the history of code. Again, very consistent with those general guidelines. So when do you report the active disease code? Well, patient has evidence of current disease. The patient is receiving treatment for that disease, or in the case of malignancies, the patient is not going to receive definitive treatment. Maybe they're going to receive some palliative care, but there's still evidence of the current disease. In those circumstances, you're going to use the Chapter 2 neoplasm code rather than history of. Let's look at an example. And here we have 3 scenarios. The first one, I have a patient with prostate cancer. We've removed the prostate, no evidence of current disease, no further treatment. In that case, we're going to use the Z code, Z85.46. We are not going to report the C61 code anymore. And that follows the guidelines. We've removed the prostate, we've removed the cancer. There's no evidence of disease, no further treatment. So we're not going to report the C61 code anymore. It's going to be a Z code, Z8546. Beginning in 2017, we get a little sort of halfway code. If we've removed the prostate, but we have a rising PSA, there's that R code that can be reported. If we have a patient, our third scenario there, if we have a patient who has clinical signs of prostate cancer, but the patient says, I don't want to do anything, or we're following that watchful waning or active surveillance, we are going to report the C61 code. And that does make sense because all you have to read is the first part of that, clinical signs of prostate cancer. Follows those general guidelines, so we do report the C61 code. Let's continue. We're going to change our example here, and we're going to look at strokes. And again, those general rules are going to apply to strokes. 3 circumstances. That event that is the acute stroke or infarction is going to be coded from category I63. And remember that's a category code. The actual individual codes will go out 6 characters here, but the category for a stroke or that infarction is I63. You're only going to report a code from I63 during that initial episode of care. It's likely going to be an inpatient event that is the acute event. So if in fact I have a stroke, you admit me for the care, that episode of care will be coded with I63 or a code from category I63. If the patient is not having the acute stroke, rather he or she had a stroke and there is some late effect, some sequela, some deficit as a result of that prior stroke, you do not report a code from category I63. Instead, you report that late effect, that sequela, using subcategory I69.3. That little dash tells you again, there's going to be some additional characters. If the patient is not having an acute stroke, had one in the past, and there are no residual deficits, then you use the history of code. So 3 circumstances. I'm having a stroke, category I63. I had a stroke, and there is some late effect, some sequela, some deficit as a result, I69.3, the subcategory code. I had a stroke, there is no late effect, no sequela, no deficit, history of. DVTs, again, we can follow those general rules for when do we use a code from chapters 1 through 19 versus the chapter 21 code, the Z code. And the rules sort of follow the same rules as you saw with strokes. First, the acute event, the acute DVT. The subcategory code is I82.4. And again, that little hyphen or dash that you see tells you that there are going to be some additional characters. But the acute DVT is coded from subcategory I-82.4. And again, you're only going to use this subcategory code during the initial episode of care. So you, clinician, find clinical evidence of that thrombus or embolus, and you initiate, presumably, anticoagulative therapy to treat that acute DVT. You report the code from I-82.4. You can also diagnose a chronic DVT. The subcategory code changes slightly. It's going to be I-82.5. Again, that little dash or hyphen tells you there will be some additional characters. You see two definitions of what constitutes a chronic DVT. One of them comes from a carrier. The other comes from the AHA Coding Clinic. That's the official publication of the authors of the code set. And in both cases, they tell you the same thing. Previously, an acute DVT was diagnosed, treatment was initiated, but out about a month, there's still clinical evidence that the clot hasn't gone away. It is chronic. And in that case, the diagnosis code reported is from this subcategory code of chronic DVT. So the acute event, and then possibly a chronic DVT. The other option is at the bottom of the slide. There was the acute DVT, you initiated therapy, and now there is no clinical evidence of the clot. And in that case, you report the history of. Now, the odd circumstance here is that the patient may continue on the same therapy. So you may have a patient that you report the I-82.4 something or another diagnosis code. That is the diagnosis code at the first bullet point. And you have a patient with the diagnosis code at the last bullet point, the history of. Those two patients have the exact same treatment regimen, that anticoagulative therapy, but a different diagnosis code, because one has the acute event and the other has history of. And that's the segue to our next slide. And that's long-term use. We also use the Chapter 21 codes to report long-term drug use. A lot of times it is prophylactic, but we also see circumstances where you use these long-term drug use codes for therapeutic purposes. All of the long-term drug use codes come from category Z79, but again, that's a category code. There are going to be some additional characters. There are some exceptions. One of them is for patients who have some drug dependence. You do not report long-term use of any type of drug dependence therapy using category Z79. You see the citation at the bottom of the slide from the coding guidelines. The example used is methadone maintenance. I would add Suboxone therapy in that as well. So if the patient is getting methadone maintenance or Suboxone therapy, that is not reported with Z79. The patient on Coumadin therapy would, in fact, you would append the Z79 code, but not with methadone maintenance or Suboxone therapy. Let's look at some other examples of long-term use on the next slide. And here you see the anticoagulative therapy. If the patient is on Coumadin, that is a Z79 category code. It happens to be Z7901. Aspirin is a little different, Z79.82. If I'm on Fosamax, actually it probably wouldn't be me, but if the patient is on Fosamax, Z79.83, very typical things that you would see long-term use of, all reported from category Z79. When you are reporting codes from chapters 1 through 19, that is, you are reporting illness and injury codes, be attentive to when you see circumstances that you're getting use additional code instructions or tip instructions. A good example is if you're reporting type 2 diabetes, very, very common diagnosis code if you think of the prevalence of diabetes. At category E11, that root code for type 2 diabetes, you will find use additional code instructions. And for the most part, if you're reporting an E11 diagnosis code, if you're reporting a diagnosis code for type 2 diabetes, you're going to report a Z79 code. Some type 2 diabetics, you are going to use a little insulin to control them, Z79.4. If you're using oral anti-diabetic drugs, oral anti-hypoglycemic drugs, you're going to report a Z79 code as well. So as you code your illness and injury codes, as you code particularly the chronic disease codes from chapters 1 through 19, be attentive to where the code book tells you, hey, particularly for the chronic diseases, if you have long-term drug use, report that as well. And the diabetes was our segue to a couple comments on documenting chronic diseases. Remember, when you document chronic diseases, in your note, a list of the chronic diseases or just a list of diagnosis codes is not adequate documentation, particularly in terms of HCC coding. At least once a year, the chronic condition is going to need to have a complete assessment. On the slide here, you see that MEEC acronym. That's been around in the coding lecture for easily a half dozen years or more. I'm at the age where I start to get a little skeptical when I see new and revelational acronyms. If you pause and read through that, clinicians, you see a mashup of the old SOAP acronym, which you were probably trained on in school. I don't care whether you use MEET or SOAP. From an auditor's standpoint, I will tell you that you need to be able to see the problem, or the auditor needs to be able to see the problem from the top of the note to the bottom. And if you think of either the SOAP format or the MEET format, that ought to make sense. I ought to see the problem in the history or the HPI. I ought to see the problem in the exam. I ought to see the problem where I look at you looking at the lab work. I ought to see the problem in the assessment, in the plan. The problem ought to appear from the top of the note to the bottom of the note. And whether you use that MEET acronym or that SOAP acronym, in either case, you get that idea that the problem ought to appear top to bottom. So it really ought to be a complete assessment. The problem ought to appear completely through the note. Don't get caught in that circumstance of just mentioning a list of problems or a list of diagnosis codes. That really never has been quite adequate. Another reminder when reporting chronic conditions, we need to be attentive to ICD-10 code set updates. And I want to stay on this slide for a moment and not only talk about what's here, but I also want to talk about what's coming up. So I'm going to talk about what's here on this slide, but I'm also going to mention something, a little caution about a 2023 update. So let's talk about what appears here on the slide, what was a 2022 update to the code set, and it had to do with depression. And generally, this is a discussion of the dynamic nature of the ICD-10, the diagnosis code set. And it has to do with this major depressive disorder. Subcategories F32.0 through F32.9. That range of codes, the subcategories, all are major depressive disorders. And the subcategories include mild, moderate, and severe, also other and unspecified. But they are all major. So it's a major depressive disorder that's mild, a major depressive disorder that's moderate, a major depressive disorder that's severe, and then the other and unspecified. Again, the emphasis there, and you see it in italics on the slide, all major depressive disorders. You get the idea of what's missing. If the patient has a mild depressive disorder or just depression not otherwise specified or depressive disorder not otherwise specified, the code set prior to 2022 really didn't accommodate that. It was not appropriate to report anything from F32.0 to F32.9. In 2022, the code set expanded with a new code, F32A. And this was particularly important, I think, for primary care. If you were treating, and I don't want to be dismissive of it, sort of low-end depression, mild depression, depression not otherwise specified, it was not appropriate to report F32.0 through F32.9. What you need to be reporting is F32A, and that is mild depression, if you will, as opposed to major depressive disorder that is mild. It's a little confusing, but I think if you sort through that, it makes sense. And again, that's what's on the slide here. And I said I had a little caution for 2023, and that has to do with the 2023 ICD-10 code set dramatically expands dementia coding. And the dementia coding dramatically expands to include mild, moderate, and severe. And dementia is defined as a major neurocognitive disorder. Where I'm heading with that is Alzheimer's dementia. If you recall, you code for Alzheimer's and then you add an additional code for dementia. So Alzheimer's dementia actually gets two codes. In dementia in 2023, you're going to have to designate it as mild, moderate, or severe. And if you use the word dementia, that is a major neurocognitive disorder. And the major neurocognitive disorder is going to have to be designated as mild, moderate, or severe. I appreciate that's a little much, but if you're thinking through it, it kind of mimics this discussion of depression. It begs the obvious question. Well, what about a minor neurocognitive disorder? And in the 2023 code set, in addition to differentiation of dementia as mild, moderate, and severe, there is also an additional code for a minor neurocognitive disorder. Now, fortunately for humanity, I do not diagnose patients. That is for you, healthcare providers, to do. And I think the differentiation between what is a minor neurocognitive disorder and what gets me to dementia, the major neurocognitive disorder that might be mild, moderate, or severe, has to do with the ADLs. Be attentive to that and be on the lookout for that as you code in 2023. And that's that whole discussion of being attentive to the diagnosis code updates. So this major dementia, major depression with the subcategories of mild, moderate, severe isn't going to go away. If you'll pardon the pun, it's actually going to get a little more severe. And with that, we'll move on to the next slide and stop beating it. A couple other items from chapter 21, including how do you report amputations. And you do sort of have to make a distinction here. Amputation for therapeutic purposes, for example, riffing back to diabetes, you have that gangrenous toe as a result of diabetes. The amputation there is actually a procedure reported with a CPT code. The diagnosis code is going to be the reason for the procedure, which will be the diabetes and the gangrene. A traumatic amputation is going to be reported out of the injury chapter, and that will be with a S code. You see a couple examples there. So pay attention to how the amputation occurs, and then we'll look at the next slide with the result of the amputation. Prior amputations are reported with an acquired absence code, and that is the Z code in chapter 21. And you see a couple examples on the slide. You should, on an ongoing basis, at least make a passing reference in the exam portion of your note. If you're taking pedal pulses and one of my feet is missing, that should get some sort of passing reference and then the appropriate diagnosis code. Similar ostomy sites, that is an artificial opening. That should make some sense. You see some examples here, very typical examples. And the same comment there. The ostomy should get a mention in the exam portion of the note. And you see my example, the colostomy bag is present and functioning. Get a mention in the exam portion, and then the diagnosis code should be reported. That's it for our little tour of chapter 21, and some of those additional information items. I'm happy to entertain questions if you all have any questions about using these Z codes.
Thank you, Bill. I did see a couple comments going about the continuing education credit. So there is a 0.5 CEU tied to Bill's presentation, and we have a certificate that we will email out to all attendees after the presentation. Essie, do we have any other questions in the chat box for Bill?
I just have one right now. It states, can many of the Z codes be used as a primary diagnosis?
Well, certainly the exam codes can be. The Z00 codes, some of the other exam codes can be. Also with the artificial openings, the attention to artificial opening codes can be. Some of the observation codes can be as well. So certainly those can be. The truly additional information codes, not so much. For example, the long-term use codes, if you think about it, that's really not a reason to be accessing healthcare services, so not so much. But a fair portion of the Z codes are a reason to be at healthcare services. And again, the obvious one is me going for my annual physical exam. Hopefully it's Z00.00. Me going for, again, not me, but perhaps my spouse or partner going for an annual GYN exam, perfectly appropriate as a reason for the visit.
Thank you. I see there are some other questions rolling in, which is great. We will take them, but for the purpose of keeping on track with all of our other speakers, we are going to have to follow up with the remaining questions for Bill in our email that is to come after this event. So please keep the questions coming for Bill even throughout the presentation. If they pop into your head, go ahead and type them into the chat box and we will get them to Bill after the presentation and follow up with the group with the answers. Thank you, Bill.
Very
We
good. Thank
appreciate
you.
you taking the time to present all of that great information for us.
Always a pleasure. Take care.
Thanks, Bill. All right, next up, we have Tim Oprasnik, Director of Contracting, and he has an important message for you. Tim, no pressure, but we got to catch up on time a little bit. So please be cognizant of the time, and the microphone is yours, Tim.
Thank you. I will try and talk a little bit fast, not too fast. I'm here to take a few minutes to talk about the No Surprises Act, and most specifically, the portion of the act that is intended to protect members from becoming victim to inaccurate information in online directories. More complete rulemaking to address the provider directories is expected later this year. The Consolidated Appropriations Act of 2021, otherwise known as the No Surprises Act, laid out a general groundwork for both payers and providers to tackle the problem of out-of-date and inaccurate directories. The law also includes some protection for patients who rely on bad information in a directory and end up with the surprise out-of-network bill. Payers are now required to verify and update the provider directories every 90 days, develop a procedure for removing providers that cannot be verified, and update the directory information within 2 business days of receiving information. The directories themselves must be available on the provider's website and include a minimum of the following details, which include name, address, specialty, phone number, and digital contact information. There's other information that, obviously directories include, but this is the minimum standard for the No Surprises Act. SummaCare's solution to this has been to contract with a vendor by the name of Better Doctor Exchange to assist with identifying potential incorrect information in our directories and obtain attestations from providers regarding the accuracy of their information. To give you just a brief example of when we started working with Better Doctor Exchange, we identified over 100 providers that were in our directory that were no longer practicing with the practices that we had them listed with. And we were never notified of those providers ever leaving the practice. So there's been a lot of improvements to our directory just right from day one of using the Better Doctor Exchange to help us identify those things. If you want to move to the next slide, there's as we work to implement these requirements, there are a lot of terms that become more critical for providers to understand what they mean and understand what actions need to be taken or what consequences will occur if the actions are not taken. I'll first kind of jump to the third item on here. The Better Doctor Exchange is, as I mentioned just briefly, or just before, is assisting SummaCare by contacting providers every 90 days to obtain attestations of the accuracy of their demographic information. We routinely submit our directory information to Better Doctor, and they provide a file that helps us identify these potential discrepancies. Accuracy, going to the top of the page, relates to the directory content. And when SummaCare identifies potential discrepancy, we will contact the providers to verify the correct information and make any necessary changes. Attestation is something that may be new to a lot of you, but is new to definitely because of this process, is that it's the process where providers complete an online questionnaire verifying the accuracy of their information. For larger groups, greater than 10 providers, Better Doctor Exchange has a roster process where a roster can be submitted to Better Doctor with the accurate information, thus saving larger entities a lot of time to when they may have 50 or 100 or sometimes thousands of providers. I just want to note this, that attestations are done at a location level. So if a provider has multiple locations, there needs to be an attestation for each location. The last item is, or no, not quite the last item, the suppression from the directory is the process that SummaCare is expected to follow if the provider does not attest to the accuracy of their information. And I'd also like to note on this is that attestation and accuracy are, even though they're related, they're two different processes. A provider's information might be 100% accurate in our directory, but if they haven't attested to that accuracy, we're expected to remove that provider from the directory. Obviously the consequences for this is that members or potential patients won't be able to find your providers in our directory, thus reducing the number of referrals you might get, or creating some questions on the patient's part whether you're still even participating with SummaCare. The last item on this page is the transparency, which is another requirement of the No Surprises Act, that we have a tool available for our members to access, to do cost comparisons for different procedures. That tool is being worked on, being developed to be rolled out probably at the end of this year. And that tool is directly related to being able to identify a provider in the directory. So if you're not in the directory, if you've been suppressed, the member will not be able to access that tool as it relates to procedures that you might be recommending they have. If you want to move to the next page, this is just a brief graph that kind of shows where we were at, and this is based upon information from August, so it's outdated and it has changed. But if you see the blue area, that is the number of providers, or the amount of providers in our network that have had attested to within the last 90 days. As you see, the dark orange area, that's the number of providers that have not attested at all. Obviously, we have been doing a lot of education in the last couple of months, because it is certainly not going to be acceptable when the day comes that we need to suppress providers, that to have roughly about 80% of our network suppressed from the directory. So that's why this is so critical that I'm here today talking about this. We anticipate, wait, let me just make sure I didn't lose track here. We anticipate beginning to suppress providers on or around January 1st of 2023. In the meantime, we are going to continue to educate providers. We're going to continue to review our data from Better Doctor Exchange for discrepancies, and we're going to continue to be contacting you to get the verification of the information that we're getting out of Better Doctor, so that we can make the changes to our directory. On your part, the most important thing that you can be doing is, for one, reviewing the information on your in our online provider directory. Review and make changes to the Better Doctor Exchange and attest to the accuracy of your information every 90 days. And as a side note too, if some of the information that Better Doctor Exchange gets is coming out of the NPI or CAQH databases. And if those things are also incorrect, then some of the information that's being fed to Better Doctor Exchange can also be wrong. So it's important to keep those things updated also. Also wanted to note that working with the Better Doctor Exchange for your attestations and that does not replace the need for you to notify us when you make a change. If you have a provider leave your office, retire, whatever reason they might no longer be with you, or if you move or change your phone number, it's important for you to just let us know of those things so that we don't find ourselves in that situation where we had those 100 doctors or 100 providers that were in our directory that were no longer with the practice. This last page right here that's out is that one right there is has some contact information, and we have links to Better Doctor Exchange on our website and in Plan Central, so that you can easily flip over and click on and get into that program. Or if you have questions, you can contact our provider support services, or you can contact Better Doctor Exchange directly, and they will help you or assist you through the process of attesting if it's your first time, or any other questions you might have. I appreciate your time today, and I look forward to seeing our numbers in that graph change drastically over the next couple of months, and definitely look forward to not having to suppress any of you from our directory in the future. Thank you.
Thank you, Tim. We appreciate you jumping on to share that information on the new regulation. In order to catch up on time, we're going to move forward, and Essie, if there are questions in the chat box, just grab them and we will follow up after our seminar. Okay, up next, we have Tiffany Marakovich, Director of Pharmacy. She's presenting on updates that you can expect in 2023 in regards to the pharmacy and formularies. Tiffany, the stage is yours.
Good morning. Thank you, everybody, for attending today. I don't have a lot of time with you, so this will be pretty quick, but you will be getting copies of the information presented here today. So we're going to first walk through the where you can find our formularies. So we'll go straight into that. Jen, to the next slide, please. Thank you. So I just want to make sure you're aware we have a lot of resources on our website, and our formularies are posted out there for you. So if you go to our website at SummaCare.com and click on the Find Your Drug, there's a little pill-looking icon on the right-hand side of the screen. You click there, and then it will bring up the next page. And then you can select which type of formulary you're looking for, what type of plan the member's on. So our Medicare formulary is listed, our Marketplace formulary, and our commercial formulary. And then if you select Medicare, you can choose to either go to a drug search tool or download a PDF of the formulary. Keep in mind, these are updated monthly, so if you download something, you probably would want to make sure you're doing that monthly to make sure you have the most up-to-date version. If you go to our drug search tool, that's always up to date. So if you'd click to use the top button there, then you can enter in a drug name. I entered Eliquis for the example here. And then if you hit search, it will bring up where Eliquis exists on the formulary. It will give you the status, which is the tier, and it will also note if there's any restrictions, prior authorization requirements for you. And then if you click on the box, it will bring up what's in the lower part of the screen and tell you that the quantity limit is actually 74 per 30-day supply. If you click on the blue text in the therapeutic subclass, I didn't put this in here, but if you click on that, you can also see what other covered agents we have on formulary related to the drug you requested. So you might find other drugs that are in lower tiers for the member or that don't require authorization or step therapy, just to help you direct the members to the most appropriate care or request those authorizations if they're required. Okay, go to the next. Another update I want to share with you, we are the name of our mail order pharmacy we've been utilizing is changing and the code you would look them up by will also be changing effective December 9th, 2022. MedImpact Direct will be changing their name to Birdie. The phone number is the same. They do have a new customer service email, and the fax or the prescriptions can be faxed to the same number. So if you're faxing those in, that doesn't change for you, and their PO box stays the same. But there will be a new NPI associated that if you're looking these up to submit electronically. So we'll make sure we get that information out to you. So again, that happens 12/9. For Medicare, I wanted to give you a few updates. You may have heard of the Inflation Reduction Act. That will have some pretty significant changes in 2023 and forward, but I wanted to highlight what's happening in 2023. So insulin claims will be capped at a $35 copay per 1 month supply. So if they get a 2-month supply, that'd be $70. If they get a 3-month supply, it'd be $105. That will be for any insulin covered on the formulary. The Part D vaccines must be covered at $0. Now, SummaCare has been covering vaccines for $0 in Tier 6 for the last few years. These can be obtained at any retail pharmacy. We also do cover the following Part B vaccines for $0, and those can be obtained at the physician's office or the pharmacy, and that would include your flu, pneumonia, and the COVID-19 vaccines. And then wanted to update you on 100-day supply. So last year we added a 100-day supply to Tier 1. This year you'll be able to get Tier 1 or Tier 6 at a 100-day supply. Keep in mind those are $0 copay for the member in the initial and the gap phase of their benefit. These tiers are designed to contain many of the medications linked to our 5-star adherence measures. So for diabetes, hypertension, and statins. And I want you to really keep in mind it only takes 3 fills of these 100-day supplies to meet that CMS adherence measure, that they'll be at 80% of days covered with 3 of those fills versus having to get all 4 of a 90-day supply. So I encourage you to start considering writing 100-day supplies for our Medicare members. And then we did add to Tier 6 some select care drugs, so it's no longer just vaccines. We added some drugs for the treatment of diabetes, cholesterol, and hypertension that were in tiers that took copays. These have now been moved into Tier 6. These are just a few examples. In the interest of time, I'm not going to read the drug list to you. You'll see that. You can also access our formulary for 2023 now, and you can see where those might fall. And then wanted, again, to give you an update of our brand over generic program. So typically we do prefer generics, but there are a few cases where we prefer a brand name over a generic medication. In those cases, the brand name will be placed in our generic Tier 2, and the brand name will either be removed from the form, or the generic will be removed or up-tiered into a higher tier. Typically, you see them remain for 6 months, but some of these have been going on longer than that. The next slide will list the drugs that apply to this program for Medicare into 2023. So Advair, Azop, Restasis, Novolog. And Novolog we're covering on Tier 2, so that's an insulin that's available less than $35 for our members. So I wanted to make sure you're aware of that. And then we'll move on to commercial. So significant formulary changes for commercial and marketplace members. We'll be putting together those lists and posting them to our website. We will also mail the list to the members so they have access to those. So you may see them bring them into your office and cite that their medication is being changed or is no longer on formulary or now requires prior auth. So we can give you a heads up to make sure that those are in place by 1/1 so the members do not have disruption to therapy. And then we also apply the brand over generic to some of our commercial groups, and this here is the list of drugs. So Adderall XR and Concerta still on this program, Advair, Humalog for the commercial side instead of Novolog, Lialda, the new Semglee, Solantra, and Visipa. And that wraps up the updates for pharmacy. I know that was quick. Oh, nope, one more, sorry. The medical drug benefit prior auth, wanted to make you aware that we do list the products that require prior authorization under the medical benefit. Those can be found at the link provided in the presentation. And new for 1/1/2023, we will be adding prior authorization to EYLEA, so that really impacts the retinal specialists that are using that medication. So that'll be a pretty significant change for us. And that wraps up the pharmacy. Thank you so much for your time today.
Thank you for your time. Lots of great information. And again, as a reminder, we will be emailing the slide deck out and following up on any questions that are in the chat box, so keep them coming. And we are going to move on to our next presenter. Next in line is Linda Easton, Manager of Clinical Management. Linda will present on care management's programs. Then I'm going to jump in and present on condition management and health coaching. Linda, go ahead and take it away.
Hi, good morning, everyone. I'm the Manager of Case Management. Wanted to just bring you some information related to SummaCare programs when you're looking for resources for your members that you might want to keep in mind. For several years, from 2009 forward, we've had a transitional care program called Bridge to Home. This program supports the member getting back to you after a hospitalization. These are for members coming out of kind of our main hospitals in the core service area. So the Summa Health System hospitals, UH Portage, Mercy Medical Center, Western Reserve. These are the hospitals that our coaches are reaching out to, both commercial and Medicare members, for all diagnoses, to make sure they understand the discharge instructions, make sure they have a PCP visit scheduled with you, look at their medications, make sure they understand them, and try to do a good med rec on there and educate on their chronic conditions. This program was a home visit program prior to COVID. As you know, COVID presented issues with home visits. So it is telephonic today with the option to do a home visit if the coach identifies something in their calls with the member that feels they need to make a home visit. The next program is a high-risk maternity pregnancy care program. SummaCare offers this, and you can see the referral information at the bottom of the slide. It applies to all fully insured and any Medicare member who might be of age to have pregnancy, and then select self-insured groups as well participate. This program just identifies our women with high-risk pregnancies, and our care managers reach out to them to assess, educate, make sure they're hooked up with their OB, and are getting the right care at the right time. Social determinants of health is evaluated, and we're assisting with that as well. Next program, Summa House Calls. So from the standpoint of those members that you might have that you haven't seen for a long, long time, they just can't get out of their home to even get to you as a primary care physician. Summa House Calls is available, and outside of our kind of core service area, Visiting Physicians Association is available also to provide that home visit in the home, the care that they need because they can't get out to a PCP. So in our core service area, Summa House Calls provides that, and outside Visiting Physician Service does. If you find that you have a member that just isn't getting to you, isn't able to, and you need a service like that, please let us know. The next program, the SummaCare Enhanced Support Program by CareCentrix. So many of you may know this program as the Comprehensive at Home Care Program, fondly called CAC in the past. We have moved this program to, the name of it is now the SummaCare Enhanced Support Program, and it's a program that spans our service area now, so Northeast and Northwest Ohio. The services are provided by Summa providers. This is home visits by an RN that's palliative trained and a social worker. We are identifying members sooner in the kind of trajectory toward end of life with this program. So if you have members who they're having difficult to control symptoms, they have caregivers who are just overwhelmed, They're frequently in the hospital and ER visits, and you feel like they need some palliative care in their home, please go ahead and refer at the bottom to the either email address or call the number there. Or you can call the number that's on these other slides for us, and we can help you make that referral. But this is for fully insured and Medicare members, self-funded members on a case-by-case basis, and for members, again, that live throughout our service area. And then SummaCare Care Management, we have 6 RNs on staff here with a social worker who are providing all levels of care management to our members, from transitioning home after hospitalizations, to finding new providers in their network, to helping them before making a referral to somebody that we need to, a hard-to-find provider, managing catastrophic situations, complex care management situations with many comorbid conditions, social determinants of health issues, any of that, our team is ready and willing and every day helping our members, all lines of business. These are telephonic visits, and if you have a referral, don't hesitate to make that to the case management email at the bottom there, or by calling the number. Thank you for your time. Jen?
Thank you, Linda. I was on mute as I was talking away. So moving on to the condition management and health coaching portion, we have Medtronic. We've partnered with them to do in-home remote patient monitoring. Members that enroll in this program will get devices mailed to their home so that they can do daily health checks. They have a team of registered nurses that monitor those biometrics and will reach out whenever they are trending abnormally. They will contact the PCP that is assigned to that member and send a trend report as well. If the member tells the past nurse that they have an upcoming appointment with their endocrinologist or cardiologist, they will send over a trend report to that physician so that they have it available before the appointment. Members also use a tablet, so they can physically take the tablet to their appointments and review those trend reports with their physician as well. If you would like to make a referral to the program, please email case management or call us at that phone number listed there. And if you have a member patient that is currently enrolled in the Medtronic program and you have questions about the program or the trend reports or want to request additional reports, you may email the PASS RN team directly at pass@medtronic.com. We have our internal condition management program. We have 2 registered nurses that do telephonic outreach for education and assessments and maybe newly diagnosed, uncontrolled A1C. We also cover these conditions that are listed below: AFib, congestive heart failure, hypertension, CAD, CKD, and so forth, asthma, depression as well. So if you have a member or a patient that is needing additional support and education with their chronic condition, feel free to email the case management team and we will make that referral. We also have health coaching. New to our health coaching team this year is a registered dietitian. So if you have somebody that is not quite qualified for medical nutrition therapy or nutritional counseling, you can refer them to our registered dietitian. It is telephonic. It is free to our members. Medicare, fully insured, MEWA, and select self-funded groups have health coaching. She is a certified diabetes educator as well as a certified health coach, and weight management experience. So if they need nutritional counseling, weight management, fall prevention is another one that she really works well with our Medicare members on. Feel free to refer them to the case management team. Okay, I'm moving right along to Sue Crawford's presentation. So she will present on Medicare 2023 highlights and changes. Sue Crawford is the VP of Medicare Sales and Market Development. Sue, you have about 10 minutes slotted for you to present. So if you'd like to go ahead and take it away.
All right, if you want to move right in.
Thank you.
So Bill mentioned that we're a 4.5-star plan out of 5, and we are waiting any day, literally the next couple days, we are going to get our 2023 star rating, and stay tuned for that exciting news. Do you want to move on? So as Bill also mentioned, this is a partnership, right? We have very high member satisfaction. That means our members, your patients, are satisfied with the care they're receiving from you and with the services that they receive from us. So we have a 97% retention rate, which is very high. And we also have a 79 net promoter score for national Medicare Advantage plans. So people ask the question, would you refer this plan to your friends and family? And 79 is very, very high. The national average is 38. So our members are satisfied with the care they're receiving from you and the service they're receiving from us. So thank you very much. Next couple slides. So we want to go over that we have 33 counties in Ohio. Lots of our consumers out there, prospects that we're trying to enroll in our Medicare plans, sometimes they think we're just an Akron plan. So we are very committed to making sure people understand that we're in 33 counties in Northern Ohio. We're just adding Erie and Sandusky back into our network. So we have those for 2023. So over 22,000 providers, over 75 hospitals. And along with our wonderful Summa Health physicians, we have many other providers in the area. The next 2 slides just list exactly what hospitals we're talking about, so we'll skip those. The next slide is when you have time to review. So there we go, back to Jade. I think so I wanted to go over the fact that we do have 7 plans. I'm not sure how many you skipped. Maybe
just one.
Okay.
It was the
hospital too. Okay, great. Thank you. So we have 7 plans. Our Amber plan does not have drug coverage. It is kind of geared toward veterans who already get their drug coverage from the VA. Our Topaz plan is our 0 premium plan. Very full coverage, medical, prescription, dental, vision, hearing, all of the extras. We have a brand new plan, which we're going to go into a little bit more detail. Our Jade plan, $19 premium, which is, I'll talk about that in a minute. And our Garnet plan is very, very full, rich supplemental benefits in that plan. And that's why it costs a little bit more at $29. And then as we get further over to the right, Sapphire and Emerald are plans that are not only HMO, but they're point of service plans, so people can go out of network for some of their care. Next slide. You can keep going, sorry. All right, so Jade with Beneflex. This is our brand new plan for 2023. This is very unique, innovative way that we have come up with. Our wonderful product development team has come up with to deliver supplemental benefits and let the consumer, your patients, our members, choose the benefits that are right for them. So we'll get right into it. Next slide. So this is why this is so unique. This is not being offered by any of our competition. We have all of the, as I said, the medical and the prescription coverage that we need to have at very rich level benefits. But we also have core benefits of dental, vision, hearing, over-the-counter items, Assist America, and travel benefits already embedded in the plan. But then what becomes very unique for the member is that they get to build their own package of benefits that they think they're going to use. So from the tier 1, they get to pick 3 benefits from massage therapy or acupuncture or new this year, fitness trackers, things like that, the nutrition coaching, They get to pick 3 from tier 1. Then you move over to tier 2 and they get to pick 1, Silver Sneakers or the Papa Pals program, which I'm sure that you've all are recommending to your patients because it's very unique. We've been one of the only plans in the area to have Papa Pals for helping around the house and just for companionship. But they can pick that or chiropractic care. And the benefits in this tier 2 are a little bit richer as far as the number of visits and things that you get than if you were to choose the Topaz plan, for example. And then on tier 3, we have a $550 flex card. That card can be used to enhance the dental, vision, and hearing benefits that the member is going to get embedded into the program. They can also choose healthy groceries, $40 a month, or a personal emergency response system or home safety at $400. So this is a very unique program and will help people focus on, instead of just having a program where everything, some level of benefit is in the plan, but they may not really be focused on it or know that it's there for them. When they're picking it, we're hoping that they are going to pick something that is meaningful to them and helps meet their needs. Next slide. This is just an example. Oh, sorry. If you want to just go back to that real quick. This is just an example for somebody can pick acupuncture, fitness tracker, nutrition, and then transportation, and then healthy groceries. So that's how it's going to work. Keep going. All right, so we also have our 6 other plans that have been around for a long time. And I wanted to have this slide in here so that you could see what's been enhanced. So for example, on our Topaz plan, we have reduced our maximum out of pocket by $200, and some of our other plans you see here, we've reduced that as well. So that means that, after folks reach that level of benefit that they've used, they will not be paying more. So we've reduced those. That helps your patients, helps our members manage their costs dramatically. We've also reduced our specialist copay on our zero premium Topaz plan to $35, and in a couple of other places as well. We also reduced on our Emerald plan our specialist copay down to $0. So now we have PCP office visits that are $0 on all our plans, and on our Emerald plan, it is now $0 as well. So this chart will help you look at some of the things that have been improved. One of the things we'll talk about a little bit more on slides to come is that we have improved our dental max for all of our plans, but the Ruby to $2,000. So we're going to go into that in a couple other slides. We've also improved our, you'll see on that other slide, we've also improved some of our vision hardware benefits and added more dollars for that. So here, this will be something that if you want to reference back to see, none of our plans have a deductible on the medical. And now none of our plans have a deductible on drug as well. But this is this page will show you the medical services. It'll show you what the premiums are for each plan. So the Jade plan we just talked about is $19, and the Garnet plan $29, and so on. So this will show you all of the highlights of that, showing that all of our plans are a $0 premium, or I'm sorry, a $0 copay for specialists, and where our low copays are, our primary care, and then low copays for our specialist visits, and so on. Next slide. This is for the Northwest. If you see 2 slides that look exactly the same, one says Jade 1, one says Jade 2. So we have some differences in the Jade plan in the Northwest region, the Toledo, Sandusky areas, if you're a provider in that area. So the next few slides we're not going to go over, but this will give you just 1 page a piece for each plan design that we have, so that you can kind of focus on the things that, if you have patients that are in these programs, you'll be able to have these references. So we have the Amber, Topaz, Jade 1, Jade 2, and then a Ruby, Garnet, Ruby, Sapphire, and Emerald. And so that's just for your reference. If you need to have that kind of detail at your fingertips, you'll have that in the presentation. So another thing that's unique to this year, if you want to move on to the next slide, is we are offering what we're calling benefit bucks with a SummaCare Visa card. So this is where we are going to put onto a Visa card those over-the-counter dollars. So if it's $75 or $100, depending on the plan that you have, we are offering in those products the ability to, get those dollars and use them for over-the-counter items at now 62,000 retailers. This year and prior years, we order through a catalog, and now we're going to be doing something different. So we're putting the dollars on a Visa card, but we're also using that card for other things. So remember reward programs, and if you choose the Jade benefit, we would load the $550. If you choose that benefit, the Flex card, or the $40 in food for the grocery card, we would load that into this card, and it works like you have a wallet or a purse where each of these dollar amounts are loaded onto the card, and they are specific to the items that they're allotted for. So we'll go into that here in a little more detail on the next couple slides. So the over-the-counter allowance benefit bucks will be loaded to the card, and those are quarterly balances that do not roll over. But they can use that on things like, their aspirin or their cough syrup or their antacids or, any of pain relievers or other things that are in the list that they can get that are non-prescription items. And we encourage people to use this to help, supplement their benefits. Want to move on? We also have our member reward for preventive care services. We give out a $50, we'll give $50 on the benefit bucks card for going to your annual wellness visit, or $10 for a breast cancer screening or colorectal screening. And again, those dollars can be used at those 62,000 participating retailers. So those would go into a separate purse for the member because it's not limited to the items. It's just they have a specific dollar limit that they now can use at those retailers. Next slide. So with the Jade plan, if they choose the $550, that is very specific to enhancing the dental, vision, and hearing expenses that they may have. So we have a $2,000 limit on most of our plans for the dental program. But there are some cost sharing and co-insurances for certain services. So they could use the $550 to bring down their out-of-pocket expense toward those services. If they choose $40 a month allowance for the groceries, again, they can use them here. You can see all of the, all of the locations. This is just a sampling of the 62,000 participating retailers that we're going to have for them to, for the over-the-counter items, or if they are choosing a grocery card. So very exciting that we will be able to make it very simple and easy for folks to just get the card in the mail, and they'll be able to go online and figure out, what money they have left over as they're using it throughout the year. Next slide.
So do you want to go through the remainder of the slides, or should we just send those out following the presentation? We have about 4 minutes left, and I was trying to squeeze Melissa in here, but we can follow up with Melissa.
No, we can't. So I would just like to say, if you need supplies in your offices, if you would like more information, if you'd like a separate webinar to go through in detail products, the sales department is available to you. We'll be happy to make sure that you have everything that you need to make sure that you understand the products that we have for your patients. So thank you.
Thank you, Sue. And these will all come to you. And like Sue said, if you have any questions, we have great great Medicare representatives that are on staff to help answer any of your questions.
Great, thank you.
You're welcome. Okay, Melissa, I know you have some great information that should be shared with our providers. So if you would like to go ahead and unmute yourself as I get to your slides. Oh, here we are.
Yep. Hi, good morning, everyone. I am last on the list of the presenters today, so I will make this quick. I know you have some other things that you'd like to get to, so thank you for attending. I wanted to talk about briefly our payment integrity journey we've been on for several years. As most of you have seen, as claims have come in, we are applying editing. And we have been using Optum CES in conjunction with Burgess Source for several years, primarily on our Medicare product line. We made a decision last year to really just go to a one-stop shop for edits, so we weren't having to manage and then also mitigate when those edits did not result in the same impact. So we did deactivate our Optum CES on 9/1 of this year, and we are using Burgess Source for all of our editing, claims editing. And editing isn't necessarily resulting in denials. It can be informational. It can have, payment implications in terms of multiple procedure reductions, things like that. So also automating some of the things we were doing manually. So as we're continuing down that journey, you've probably also seen edits around MARS. So MARS is the abbreviation, marsauditor.com. If you have any questions about services are impacted by MARS edits, you would reach out directly to them. On your explanation of payment, it will give you the website to follow up on. And that would be the same for any of the high dollar edits. Those probably are not impacting any of you directly, but more on the facility side. And then we have engaged with a vendor to look at fraud, waste, and abuse in the essence of really around unbundling, upcoding, things like that, where we're seeing trends, modifier utilization. So in that case, we might reach out and ask for some records to take a look at that, the billing that has come into us on a claim, and really if the record is substantiating the claim, there is no issue, but it's just part of our due diligence. We're required by both CMS and ODI. Next slide, please. So as we've made this transition from CES to Burgess Source, we've had some bumps in our adjustment tracking. So you can see that we had some additional adjustments associated with just kind of getting a steady state on our edits. So we're starting to kind of come back down to our pre-implementation work. So that is starting to track in the right direction. And I hope you're seeing that as well. Next slide, please. So just from a call to action perspective, please continue your active dialogue with provider engagement and provider support services. As those calls or questions come in, we're documenting those on an issue log, and we're working those on a daily basis and getting that information back to you. We're also willing to participate in a provider call regarding any edits that you might be seeing. We've done that in the past. It's been really beneficial, not only for our team, but also for the provider offices. And then one additional item, when we went to Burgess exclusively for edits, now all of the edit detail is on Plan Central. So if you bring up a claim and you look at that detail, you'll be able to see the edits and the background behind those edits. So we're hoping that that will also give you more information if you have any questions. So that's the end of my presentation. I just wanted to thank you for your ongoing collaboration and support. And we're here and ready to work with you if you have any questions.
Thank you, Melissa.
Thank you.
I appreciate you condensing that into a quick 3-4 minutes.
No problem.
And lastly, as we close out this event, for those who have stayed a couple minutes later, thank you. I appreciate that. Please visit our website. We are continuously updating our provider page with lots of great information. We have all of our newsletters, memos, education, such as this Think Cultural Health. There is a link to the hhs.gov website where you can obtain a cultural health education. We also have our information on provider support service. So if you have any benefit program questions, things around claims, authorizations, how do you register for Plan Central, give that team a call or an email. And we have our provider engagement specialists that can help coordinate education, training. If you have new staff or if you're new to SummaCare, we'd be happy to onboard you or provide a refresher training. We share care gap reports, can help you with the HSM program referrals and things like that, as well as follow us on social media. We're on all the socials. We post lots of education and news. We have blogs. And if you are not currently getting our e-newsletter, if you can register for Plan Central, but if you don't need full Plan Central access, you can just go to our website and register for our communications there. So you have two options. If you're already registered for Plan Central, you're on our email list, and you can also register online. So thank you very much for attending this event. We know it was jam-packed with lots of great information. And as promised, we will send the slide deck with the CEU certificate sometime today. So thank you for your participation, and we hope you all have a great day.